You know how sometimes medical exams, like the MSRA, can feel a bit like you're trying to nail down jelly, especially with specific conditions?
Yeah, absolutely. It can be tough.
Well, today we're really digging into one that pops up quite a bit: atrial fibrillation, AF.
Right, AF. It sounds complex, but I mean, at its core, it's basically the electrical system in the heart's upper chambers, the atria, going a bit haywire.
Haywire how?
Well, imagine an orchestra where a section suddenly starts playing its own fast, chaotic tune. It messes up the whole rhythm, so you get this irregular, often rapid heartbeat.
And it's important because it's not rare, is it?
Not at all. It's actually the most common sustained heart rhythm problem. So understanding it is crucial, definitely for the MSRA, but also just for, clinical practice.
Okay. So our mission for this deep dive.
Let's pull out the really key exam-focused stuff about AF from the notes we've got. We'll try and make it clear, concise, and hopefully memorable.
Sounds good. Let's unpack it. So starting right at the beginning, the definition, what is AF really fundamentally?
Okay, so it's that irregular and rapid electrical firing in the atria. Because it's so disorganized, the atria don't squeeze properly.
Right.
And that leads to an irregular response from the ventricles, the lower chambers, too.
And for exams, what are the absolute key signs we need to look for?
The big one is the irregularly irregular pulse. That phrase is classic AF.
Irregular. Okay.
Yeah. And sometimes you might find a disconnect between the heartbeat you feel on the chest, the apex beat, and the pulse at the wrist. They don't line up properly.
Gotcha. So why is this such a big deal? What are the main consequences?
There are two really major concerns. First, because the atria aren't squeezing well, blood can just sort of pool there, stagnate.
Which sounds bad.
It is. It seriously increases the risk of a blood clot, a thrombus, forming. And if that clot breaks off and travels, well, that's an embolism. Most worryingly, it can cause a stroke.
Okay, so stroke risk is huge.
Absolutely huge. A massive focus of management is reducing that stroke risk.
And the second consequence?
The heart just isn't pumping as efficiently. The overall cardiac output can drop because the atria aren't contributing properly.
And that matters more when?
Especially during exertion, yeah, when the body needs more oxygen. And over time, this inefficiency can actually contribute to heart failure.
Right. Makes sense. Now, you hear about different types of AF. It's not all the same.
No, exactly. We tend to classify it based on how long it lasts and whether it stops by itself. There are 5 main types.
5. Okay.
Yeah. You could maybe think. APRPP, almost perfect rhythm, possible permanently. It's a bit silly, but helps remember the order.
APRPP. Okay, let's try it. First A, acute.
Acute AF. That's when it started within the last 48 hours. It needs checking out pretty quickly. Acute equals act now.
Got it. P, paroxysmal A.
Paroxysmal AF. These are episodes that stop on their own, usually within 7 days, often much quicker, like less than 48 hours. They come and go.
Intermittent.
Exactly. But it's worth noting, it can eventually become more persistent.
Okay. Are recurrent.
Recurrent just means someone's had 2 or more episodes. Simple as that. Now, if those episodes stop on their own within 7 days, it's still called paroxysmal.
Ah, okay.
But if you need intervention like cardioversion to stop it, then we're moving into the next category.
Which is the second P, persistent?
Persistent AF, yeah.
Yeah.
This is when it lasts longer than 7 days. Or it needs medical help, drugs, or electrical cardioversion to get back to a normal rhythm. It doesn't stop by itself.
Needs intervention. Okay. And the final P, permanent. Sounds final.
Permanent AF. Usually this means it's been present for over a year, and attempts to cardiovert haven't worked or haven't been tried. But, permanent isn't always forever.
Yeah.
If you can treat an underlying cause, sometimes it can revert.
Okay, so APRPP. Acute, paroxysmal, recurrent, persistent, permanent. Timeframes and intervention are key. Right?
Okay.
What actually causes AF?
Well, most of the time, we can find a cause. But interestingly, there's this thing called lone AF.
Lone.
Yeah, where you do all the tests, everything looks normal, but the person still has AF. Maybe up to 11% of cases. It's actually more common in the paroxysmal type, maybe 30, 40%. Makes you wonder if the mechanism is slightly different there.
Interesting. But for the identifiable causes, how can we group them?
You can think of common cardiac ones, maybe CHV, coronary heart disease, hypertension, valvular heart disease. Those are big ones.
CHV. Good mnemonic.
And don't forget thyroid problems like hyperthyroidism. That's a really important non-cardiac one to check for.
CHV and thyroid. Okay. Any other heart-related causes?
Oh, yeah, plenty. Rheumatic heart disease, problems with the heart's natural pacemaker like sick sinus syndrome, pre-excitation things like Wolff, Parkinson, White.
WPW, that rings a bell.
Yeah, WPW is important because AF in someone with WPW can lead to incredibly fast ventricular rates. Dangerous stuff.
Yeah.
Especially if you give them standard AV node blockers.
Right. Good point. What else, cardiac?
Heart failure itself, cardiomyopathies, pericarditis, myocarditis, holes in the heart like ASD, other congenital issues, even rare things like atrial myxoma.
Okay. And outside the heart, non-cardiac causes.
Yep. Some drugs can trigger thyroxine, certain bronchodilators. Acute infections are a big one, including COVID-19, actually.
Really?
Yeah. Also, electrolyte problems, lung cancer, PE, definitely thyrotoxicosis again,
Yeah.
and diabetes.
And lifestyle stuff.
Sure. Too much caffeine for some people, definitely excessive alcohol, and obesity is a major factor too.
Yeah.
Things patients might actually be able to modify.
Okay, causes covered. What about risk factors? Who's more likely to get AF?
There's a good mnemonic for this too. AHHDO-SCPF.
AHDOSCPF. Let's break that down.
Okay. A, advancing age. H, hypertension. H, heart failure. D, diabetes. O, obesity. S, sleep apnea. C, chronic kidney disease. P, prior stroke or TIA. And F, family history of AF.
Wow, okay. AHHDOSCPF, quite a list. Does AF hang out with other rhythm problems?
Yeah, it often does. You quite commonly see it with atrial flutter, sometimes even alternating between the two.
Flutter can turn into AF.
It can, yeah. Or sometimes flutter appears when you're treating AF with certain drugs. And like we said, it can coexist with SCTs.
Then that WPW interaction is key.
Absolutely critical. AF plus WPW can equal dangerously fast ventricular rates, potentially leading to VF, especially if treated incorrectly with AV nodal blockers. Got to be really careful there.
Definitely noted. Just briefly, pathologically, what's happening inside the heart muscle and electrics?
It's basically abnormal electrical signals firing off all over the place in the atria, plus often some structural changes in the atrial tissue itself that mess up the normal conduction pathways.
Yeah.
Chaos, essentially.
Electrical chaos, got it. So if someone comes in with a fast heart rate, AF is high on the list, but what else should be on our differential?
Good point. You need to think about other tachycardias. Could it be atrial flutter? Just frequent atrial extrasystoles? Other types of SVT like AV and RT?
Or even just sinus tachycardia.
Sinus tachycardia,
Yeah.
And definitely keep WPW in mind and the more serious ventricular tachycardia, VT. Got to rule those out.
Okay, thinking big picture, how common is AF? What's the epidemiology like, say, in the UK?
It affects around maybe 1.5 to 2% of the whole UK population. It is the most common sustained arrhythmia we see.
1.5 to 2%.
Yeah, and in adults overall, probably 2 to 4%. And that number is expected to rise, maybe more than double, mainly because people are living longer and we're getting better at spotting it.
And it definitely increases with age.
Massively. You get up to 75 plus phase, and it's around 10% of people. Huge jump. It's also a bit more common in men, and definitely more common in people with those risk factors we listed: hypertension, heart failure, diabetes, obesity, kidney disease, etc.
So how does it actually present? What might a patient tell you, or what might you find?
Symptoms can vary a lot. Some people feel nothing, but common things are palpitations, that feeling of a racing, fluttering, or irregular heartbeat.
Okay.
Also fatigue, just feeling wiped out. Shortness of breath, maybe dizziness, occasionally even fainting, syncope. Chest pain isn't as typical, but it can happen.
And on examination, the pulse.
Feeling the radial pulse is key. You're listening, well, feeling for that irregular rhythm. That's the classic physical sign.
Any tools that help?
There are some automated blood pressure machines, like the Watch BP Home A, that can flag an irregular pulse during a reading. Quite useful, especially in primary care.
Right. So you suspect AF. What are the first-line investigations?
ECG, absolutely essential. That's where you'll see the lack of clear P waves and the variable RAR intervals. That confirms it.
Unless it's paroxysmal and they're not having an episode right then.
Exactly. If you suspect paroxysmal AF, but the resting ECG is normal, you need longer monitoring, like a Holter monitor, 24 or 48 hours, sometimes longer, to try and catch an episode.
Makes sense. What about an echocardiogram? Echo.
Echo is really important. A standard transthoracic echo, TTE, gives you crucial info about the heart's structure and function. Is there valve disease? Is the heart enlarged? How well is it pumping? It helps guide long-term management, especially if you're thinking about rhythm control, and helps with that stroke risk assessment too.
Is there a role for the transesophageal echo, the TO?
Yes, sometimes. If the TTE isn't clear enough, or specifically if you're playing a cardioversion, a TOE gives a much better view of the left atrium to make absolutely sure there's no clot lurking there before you shock the heart back into rhythm.
Right. Safety first. What about blood tests?
Key ones are thyroid function tests, TFTs, because thyroid problems are a common cause. Full blood count, FBC, check for anemia, kidney function, electrolytes, liver function tests, LFTs, and a clotting screen, especially if you're thinking about anticoagulation.
Any other scans?
A chest X-ray can sometimes show underlying structural issues like valve disease or heart enlargement. And of course, if you suspect they've had a stroke or a TIA, you'd need a CT or MRI of the brain.
And those portable ECG devices?
Things like CardioMobile can be useful for patients with infrequent symptoms, allowing them to record an ECG when they actually feel the palpitations.
Okay, comprehensive workup. Now, those scoring systems you mentioned, CHA2, DS2, VASC, and HAS-BLED.
Yeah, they're fundamental for management decisions.
Yeah.
CHA2, DS2, VASC is all about assessing the annual risk of stroke in someone with AF.
How does it work?
It gives points for different risk factors. C for congestive heart failure, H for hypertension, A2 for age 75 or older, that gets 2 points, A for age 65, 74, 1 point, D for diabetes, S2 for prior stroke or TIA, that's 2 points as well, V for vascular disease, and SC for sex category. Female gets a point, though the guidance around that 1 point is nuanced.
And the score tells you what?
Basically, whether to anticoagulate. Score of 0 in men, generally no anticoagulation. Score of 1 in men, you consider it. Score of 1 in women usually doesn't automatically trigger anticoagulation anymore based just on sex. But a score of 2 or more for anyone means anticoagulation should definitely be offered.
So it's guiding that stroke prevention.
Precisely. And then you need to balance that against the bleeding risk if you do start anticoagulation. That's where HAS-BLED comes in.
HAS-BLED.
Yeah, it stands for hypertension, abnormal renal liver function, 1 point each, stroke history, bleeding predisposition, labile INRs, if on warfarin, elderly, over 65, drugs, alcohol, 1 point each. A higher score means a higher risk of bleeding on anticoagulants.
Does it tell you not to anticoagulate?
Not usually. It's more about identifying factors you might be able to modify to reduce bleeding risk and helps guide the choice of anticoagulant. There's also another score, ORBIT, which looks at similar things like hemoglobin, age over 74, bleeding history, kidney function, and antiplatelet used to stratify bleeding risk.
Okay, risk assessment sorted. How do we actually manage AF day to day?
It really boils down to 2 main strategies running in parallel: rate or rhythm control, any reducing that stroke risk.
Let's start with rate versus rhythm.
Okay, so rate control is about slowing the heart rate down to improve symptoms and efficiency, even if the rhythm stays irregular. This is the approach used for most people with AF.
How do you do that?
First line is usually a beta blocker, or a rate-limiting calcium channel blocker like diltiazem. Verapamil is another option, but generally avoided if there's heart failure.
And if one drug isn't enough?
You can use combination therapy, maybe a beta blocker plus digoxin, or sometimes diltiazem plus digoxin. Digoxin is less often first line now, but still has a role.
Okay, that's rate control. What about rhythm control? Trying to get back to normal sinus rhythm.
Rhythm control is usually for younger patients, those who are very symptomatic despite rate control, or maybe if it's their first episode. The aim is to restore and maintain normal rhythm.
How?
2 main ways: pharmacological cardioversion with drugs, or electrical cardioversion using a controlled shock. Electrical is generally more effective.
But there's a risk.
Yes, the risk of dislodging a clot when the rhythm changes back. That's why anticoagulation is absolutely vital before and for at least 4 weeks after electrical cardioversion, unless you're certain the AF is very recent onset or a toe has excluded a clot.
So rate control is more common?
Yes, for many patients, especially older ones with other health issues, good rate control gives similar outcomes to rhythm control regarding stroke and mortality, potentially with fewer side effects from antiarrhythmic drugs.
Right. And the other pillar, reducing stroke risk.
That comes back to the CHA2 DS2 VASC score. If the score indicates it, anticoagulation is offered.
What are the options there?
The main choices are warfarin, which requires regular blood test monitoring, INR, or the direct oral anticoagulants, DOAC drugs like apixaban, rivaroxaban, edoxaban, dabigatran.
And they don't need the same monitoring.
Generally no routine coagulation monitoring, which is a big advantage. The choice depends on individual factors like kidney function, other medications, patient preference, and bleeding risk.
Okay, so what's the long-term picture? The prognosis?
It really varies depending on the person's other health problems, their age, and crucially, how well that stroke risk is managed. If AF is well managed, especially with anticoagulation when needed, the outlook can be good.
But AF itself carries risks.
Definitely. It significantly increases the risk of stroke, as we've hammered home,
Yeah.
and also the risk of developing or worsening heart failure.
What about after someone's already had a stroke?
If they have AF, UNIC guidelines recommend anticoagulation, usually starting about 2 weeks after an ischemic stroke, assuming no bleeding complications. They might also need antiplatelets if they have other vascular disease.
Does AF affect lifespan?
Unfortunately, yes. Older patients with AF tend to have a reduced life expectancy and roughly double the risk of mortality compared to similar people without AF. And persistent, poorly controlled fast rates can eventually damage the heart muscle itself. That's tachycardia-induced cardiomyopathy.
Is there anything people can do to prevent AF?
Well, managing the risk factors we talked about is key. So controlling blood pressure, managing diabetes, maintaining a healthy weight, also lifestyle things. Stopping smoking is huge for overall heart health.
Alcohol and caffeine. Moderating alcohol is important, as heavy drinking is a known trigger. For some individuals sensitive to it, reducing caffeine might help prevent episodes, though the evidence isn't super strong for everyone.
Okay. Finally, just to summarize the potential downsides, what are the main complications of AF if it's not managed well?
Big list, unfortunately. Stroke or systemic embolism at six-fold increased risk is the headline. Heart failure precipitating it or making existing failure worse. Cardiomyopathy from the fast rate. Ventricular arrhythmias, though less common. Reduced quality of life due to symptoms. Increased mortality. And more hospital visits, more healthcare costs. It has a big impact.
Right. Okay, that was a lot, but really useful. Let's try and crystallize the absolute key takeaways for you, our listener, especially thinking about the MSRA.
Okay. AF's irregular electrical activity in the atria. Key sign irregular pulse. Major worries, stroke risk.
Assess that risk with CHA2DS2 VASES. Remember the basic types APRPP, and management focuses on two things.
Rate or rhythm control, and absolutely crucial anticoagulation based on that stroke risk assessment.
Getting those core ideas down is vital, isn't it? Both for the exam and just for being a good doctor.
Couldn't agree more. It's fundamental knowledge.
So for more detailed revision, loads of practice questions to really test yourself for the MSRA, do check out passthemsrod.com.
And don't forget the free resources available too, over at freemsred.com. Definitely worth a look. Keep plugging away at your learning.
Yeah, keep going, and maybe just mull this over. Picture a patient presenting with palpitations. How would knowing the type of AF they might have and their risk factors change how you approach them initially? Thinking that through helps solidify it all.
Absolutely. That link between the classification, the risks, and the first steps in management is key, not just for exams, but for actually helping patients effectively.